what are reasons why people would not adhere to a antiretroviral regimen?
This is really the heart of our program. It's it's who we exist for. We exist for the people who are so vulnerable, and kind of we call it the last 5%. Like those people who have fallen between the cracks and who have defaulted from their lost to follow up. They're not on their regimen anymore. And the primary reason for non-adherence in HIV or in any type of long-term chronic illness management is a sense of self-worth. We have the whole approach. The whole approach is based on we can't expect our clients to heal physically until they heal spiritually and emotionally.
Hello, and welcome to the Simple Charity Podcast, a show about learning to love generously like Jesus. I'm your host, Brian Grasso. Human immunodeficiency virus, or HIV, is a disease that attacks a person's immune system, and if left untreated, becomes acquired immunodeficiency syndrome, or AIDS. A person with AIDS has a severely weakened immune system that can make infections like tuberculosis deadly. Today on the show, I talk with Molly Heacock, the soon-to-be CEO of Untold, a nonprofit with a program that has reached tens of thousands of HIV-positive people in sub-Saharan Africa, helping them live a life beyond AIDS. Molly and I actually first met at a graduation ceremony for Untold in a slum in Nairobi. And in our conversation, we talk about the history of the HIV/AIDS epidemic and why, as Molly puts it, stigma is more deadly than sickness. We discuss the social narratives surrounding HIV, both in the US and in Africa, and what we can learn from Jesus about the call to love stigmatized neighbors. Finally, I ask Molly to share an update on PEPFAR, and she shares some good news about the current status of the policy that has made AIDS medication available around the world. Join me for a conversation about why the psychological, social, and spiritual effects of HIV are often a greater challenge than the biological ones. If you're listening to this podcast, this is your show, so as always, please send me your thoughts, questions, and suggestions at brianwithny@simplecharity.org. And if the show is helpful, please click a 5-star rating in your podcast app. Also click like and subscribe. All these little actions help out the show a lot to get it out to more listeners. Thank you so much for taking those little actions. I'm so glad you're with us today.
Hi, my name is Melissa, and I serve as a Simple Charity philanthropic advisor to individuals, couples, families, foundations, and family offices in the Raleigh-Durham, Chapel Hill area of North Carolina, but also to clients around the country. If you're curious about your own generosity journey and would like help thinking through a philanthropic strategy with intentionality to discern where God is calling you to love people, to find excellent nonprofits to partner with, or to understand the impact of your current grant making, I would love to connect and share more about Simple Charity's philanthropic advising offerings. You can connect with me at melissahall@simplecharity.org. That's melissahall@simplecharity.org. And you can learn more about us at simplecharity.org. That's simplecharity.org.
Molly Heacock, welcome to the Simple Charity Podcast.
Thank you, Brian. I'm so glad to be here.
Molly, what are you grateful for today?
I am grateful for so many things today. I'll say something that's kind of silly, and it's just like a free ad for this group. But my family and I just joined a CSA. It's like a community-supported agriculture box. And so every Tuesday, which is today, we get a local farm box delivered. And it's like the only time in my kids' lives, I have a 5-year-old and a 2-year-old, where they've been excited about eating vegetables because it's like this fancy box full of cool stuff. So I'm thankful for Fresh Harvest, which we're using for our Georgia CSA.
I love it. You know, my wife and I had one of those for a season when we were in Durham. And one of the things that was fun was all the vegetables we got were kind of funny looking. Like they weren't bad. They were just misshapen. And I guess
they're
the idea is people don't buy them. Yeah. Yeah.
Exactly.
And it is kind of dumb to think that
I know
so much food would go to waste just because it looks funny.
Yeah, it's the same. And there's stuff I've shamefully never even heard of that I'm like, well, how do I make this? So it's super fun.
Yeah. Molly, I like to try to sometimes take the small talk at the beginning of these podcasts and segue into the topic somehow and make a connection. But I got nothing here. I have no idea what misshapen vegetables at CSA have to do with your work at Untold. So let's just dive into it. So tell me about Untold. You are the CEO as of a couple months ago.
April, actually, coming up here very soon, the next couple of weeks.
Oh, so you will be the CEO. Oh, sorry. So by the time people listen to this, you will probably be the CEO of Untold. Right. So what is Untold? Just give us a quick overview of your mission.
Yeah, so it's honestly helpful when I talk about Untold to someone who's totally not familiar. I'll explain what the name means first because it's like a little bit squishy, a little bit confusing. But the name Untold, it really focuses on the fact that our mission is that we exist to embrace and equip people to live a life beyond AIDS. And the reason that our brand is called Untold is because we specifically, through our really integrated approach to counseling and healthcare, we embrace clients so that they are safe enough to tell the untold stories of their past. And we'll talk about stigma and HIV, kind of the silence that often accompanies the diagnosis later in the podcast. But we equip people to tell the untold stories of their past, and then we equip them to live into the untold stories of their future. So our vision is that we really deeply believe in a world where no story is cut short or silenced by AIDS, and we're proud to play a small part in creating that world through the work that we do in East and newly South Africa.
Oh, wow. That's awesome. And what was your journey towards Untold? How did you get involved in this work?
I love that question. And honestly, every time I'm asked, I have a potentially different answer. I've been accused many times of being a cause agnostic, which essentially means that if you tell me a great story about a great, justice-oriented organization or person or story, I'm all in. I don't particularly feel quote unquote called to HIV or to homelessness or to women's issues, all of it. I want all of it. I want to be involved in every single part of God's big story of affirming dignity in people, whether they're in East Africa or in Atlanta, my own family, I'm all in on that. So my journey to Untold really wasn't initiated by any specific deep passion about HIV in particular. I've been at Untold for 13 years. So it's really
been that long, Molly. That's a long time.
Has. Yes. I may be a cause agnostic, but I am committed.
Yes.
So I joined the team about 13 years ago. And previously I was working in Atlanta with men and women experiencing homelessness. So in that job, I really kind of cut my teeth in philosophically, you can talk about and think about, especially in college, I would talk and think about inherent dignity and how everyone is made in the image of God and, biblical shalom is justice and all this stuff. And it's great theoretically and it's great, theologically. And then you get into it and it's really,
it's still
really
great. It's still great the entire time. And there's never any challenges.
You just never have a bad day. You never need a mental health break. But I really cut my teeth and learned so much about what it really means to be in people's stories with them through the hard stuff in the long run. And I thought I would be doing work with people experiencing homelessness and mental health disruptions in Atlanta forever. But my path intersected with Justin Miller, who's our U.S. co-founder, and the vision that he had even 13 years ago to be a partner to our African team, not to be directive. He didn't start it. He funded it. The idea was born in Kenya by Kenyans. And that vision was so compelling to me that I took a chance and joined the team 13 years ago. And I've fallen deeper in love with it every day.
Yeah.
So it's kind of, to any college kids listening, it's an encouragement that sometimes you don't have a specific quote unquote calling on your career. Just follow the next best thing. Yeah. And it could be the thing.
That's right. And honestly, any philanthropist listening to this as well, I
Yeah.
think I think there's actually a theological case for being, quote unquote, cause agnostic, and that God tells us a broad range of things to
Yeah.
care about. And I think Christians can care about and do care about. And there are different people in the body of Christ doing all these sorts of things. But as far as what very specific, very particular work
Mm-hmm.
of mercy and justice each of us are doing, there's something extremely kind of circumstantial about that, providential.
Yeah.
And the idea to be cause agnostic and then to be loyal to the group of people God has brought in front of you to love, actually, I think is a great model for all of us. So, so you lived in Nairobi for a portion of those 13 years. We actually met in a slum in Nairobi back in 2019. My wife and I were visiting Kenya and just visiting a number of different ministries and just kind of a learning trip. Kenya has a place that has deeply impacted me. My wife had never been, so I kind of dragged her all around the country for 3 weeks, and that was really fun. But yeah, tell us about when you were living overseas and that part of the journey.
Yes, it's one of my favorite seasons of my husband and I's marriage. It was also absolutely not what we necessarily planned. I mean, my husband is really quite a saint and is talk about like just saying yes to the next best thing. We had maybe one conversation when I came home from the office one day and said, "Do you have the imagination to move to Kenya like in the next 6 months?" And, that was one conversation. He said, "Yes, absolutely." Left his job of 10 years and we moved to
Holy cow.
Nairobi. Yeah, it was amazing. His phrase with all of that, which is a typical leadership phrase, but I loved it applied to our particular life scenario then, was that it's hard to go from good to great. We had a really, really good thing going here in Atlanta. And he was like, yeah, I mean, there's tons of what ifs, but he felt really, deeply that this was going to be like the good to great move in our marriage and in our life. And it was. And I in particular had all these plans about how I was going to, do my listening tour and spend X number of days in the office, X number of days in the field, visit all of I think at the time we had 80 something centers. And I got to do that for about 6 months. And then COVID, well, I guess, more than 6 months. And then COVID hit.
Wow.
And it turned out we were surprise pregnant with our son. We found that out on New Year's Day of 2020. And we were like, well, we'll stay. We'll have a great pregnancy in Kenya. It'll be great. And then COVID hit. And we kind of had a really different experience than we imagined for the rest of our time in Kenya. But it was incredible. I mean, we got to talk about public health experience. I have my master's degree in public health, and similar to when I was working at the homeless shelter, it was like, okay, I'm putting a lot of theory into practice right now. Like, how do I transition our entire program alongside our leadership team to a telehealth model? How do we really talk about social isolation in a way that's not going to further exacerbate the stigma that our clients already feel with their HIV status?
Right.
So our time there was really formative. It was really amazing. We are in love with Nairobi in particular. And we came back to the States to give birth to my son. And since then, we've been going back to Kenya every summer, bringing the kids with us. And we'll spend 4 to 6 weeks, and I'll work out of our Nairobi office, just so we can continue to invest in those relationships. Anyone who's worked in Africa in particular knows that in-person experiences build relational equity 10,000 times more than a Zoom call ever could.
Yeah.
So we still feel like a part of our heart is like very deeply buried in Nairobi in particular. We just love it. Love that city.
Yeah, that's fantastic. I love that you're just bringing your young kids. I have a 5-year-old son as well, so our kids were probably born COVID baby around the same time. But I just love doing stuff with young kids and just trying to like show the world like, if you have young kids, you can still do stuff. Like you can travel, like you can, and you got to figure it out. But so just shout out to I guess having more kids. I don't know.
Yeah. I have some colleagues in international development, or even folks who I know who are just about to travel with their kids, who are always like, What's your secret to, all the flights and stuff with kids? And it's to lower your expectations.
Yeah, yeah, yeah.
There is no other secret to traveling with a 2-year-old.
It's good. Well, let's talk about HIV/AIDS, and I want to talk about the history of the HIV/AIDS epidemic. I think this is really important because it'll set some context, and then we'll get into Untold's programs today. But I want to set some context because I do think that um, AIDS was kind of in the news. That peak felt to me kind of early 2000s, and I think this is not a season right now where HIV/AIDS is a social justice cause that is very commonly publicized, talked about in the media. And so
Yeah.
I could you just share a little bit about kind of over the last 2 or 3 decades, what has the AIDS epidemic looked like? I think it started in the 1990s. There was kind of antiretroviral therapies that were developed and it took a really long time to get them into market. That's a whole interesting story. And then I think there was this perception. I'm doing this already. I'm going to finish this thought, and then I'm going to let you add to
You
the
know more
picture I'm
than the
trying to
average
paint.
person, for sure.
So I think in the early 2000s, there was this idea of AIDS as a death sentence. There was a orphan crisis in East Africa around AIDS, and then at some point a switch flipped, and AIDS was no longer a death sentence. I would say, in terms of our understanding of the medicine, like I think most people don't know that you can get people's viral loads down to nearly zero, that you can prevent mother to child transmission, that actually it is possible to live a life beyond AIDS. Like I think even today, in a lot of I don't know, if you're not paying attention to this cause. I do have a degree in global health, so this is how, and I took a class called Narratives of Living with HIV/AIDS.
There you go.
At
So that's
Duke.
why.
So yeah. So that's why. So I've tried to remember all that. It was 7 or 8 years ago now. But what would you add to that story of how the epidemic has changed, really, over the last 3 decades?
It's changed so massively, and the medication is a huge part of it, to your point. Anyone who's interested kind of in the deep history of the virus in particular, and kind of the science around that, and the best guess, an epidemiologist's best guess of the origin is really in Central Africa, modern Congo. Back long before it was ever on the radar of the West. And there's a Radiolab episode. I can't talk for 20 minutes without mentioning a Radiolab episode. It's my favorite podcast, second only to this one.
Hey,
Um,
that's our
but
answer, Molly. Thank you.
there you go. The episode is called Patient Zero. And so if you want to do a deep dive into kind of the history of the virus itself and how it's a spillover virus from, it was simian immunodeficiency virus was the initial virus that spilled over into human beings, perhaps most likely in the Congo in the 1920s or even earlier. And then with the increase of trade and globalization, it really obviously hit the United States radar in the 1980s. And anyone who is old enough to remember kind of the heyday, that's like, for lack of a better word, of the AIDS epidemic in the 80s, it was primarily among certain populations, and there was a huge social stigma around that, even in the US
Yeah.
at the time. But then globally, to your point, it was so considered a death sentence because medication was not widely available in any sense of the word in sub-Saharan Africa, but also not designed the way it's designed today. So antiretroviral therapy really kind of took a huge turn. The production and the science behind the medication took a huge turn in 1996, which is kind of why that's like a huge point in the timeline of like death sentence. Oh, actually, we have this medication now starting in 96
Right.
that can functionally move it from a death sentence to a chronic illness. So you're always going to be HIV positive, but you can achieve viral suppression. You can live a long, healthy, really beautiful life, just managing the disease with this medication. So it took a while for that medication to be widely available in sub-Saharan Africa and accessible. Availability and accessibility, of course, are two sides of a coin. They're different. And for the clients that we serve who are living in extreme material poverty, really until the late 90s and early 2000s, the medication was not accessible. So you see this like stark transition post 90s, 2000s orphan crisis when Bono was
Yeah.
talking about
Yeah.
it all the time. It was, the one of the most massive global health crises the world has seen. Um, and in fact, I think since the beginning of the epidemic, as far as it's been tracked, about almost 45 million people have died
Wow.
around the world from AIDS-related deaths.
Hmm.
And so it's massive. And really what's changed most significantly in the past couple of decades is the science behind the medication, so the efficacy, the availability, and the access to antiretroviral medication. Around that, though, the kind of social commentary and cultural understanding of the disease has really evolved really significantly in
Hmm.
the US and also evolved really significantly in sub-Saharan Africa.
Unpack that. I'm curious about
Yeah.
both stories. I'm curious about as you meet with Untold donors and constituents in the U.S., what myths or preconceptions do you think they tend to have around AIDS today? And then
Yeah.
as you're overseas in Nairobi, what is the social narrative of this disease today?
Yeah, absolutely. I love that question. And really, depending on how old you are, what you've experienced culturally, younger people, I've had conversations where it's like, oh, is AIDS still a thing? Like, because it's just so not on the radar
Right.
culturally. Which I
Who's
think,
Bono?
yeah, exactly. It's like, what's happening? So there's definitely a narrative for people who can't remember the height of the US or global crisis that it's like, oh, I thought we cured that. I thought we dealt with that.
Oh, wow.
Um, and so there's certainly some education around, it being a chronic disease, it not being curable as of today, but the medication being available to manage it. And then there's also kind of, these perceptions around, oh, well, how did someone contract it? Because, and I'm going to get use some health terms. We're going to talk about sex on the
Go for
podcast.
it.
Maybe your first time doing
No, I
it.
think we talked about sex on the podcast this morning on a different interview. So,
Well, there you go. Perfect. Who knew? But there is this perception because of how the virus is contracted that either someone has been sexually promiscuous, they might be using intravenous drugs, they might be engaging in a same-sex relationship. There are these kind of like cultural assumptions about the morality of the person who's HIV positive,
yeah,
generally across the
U.S.
globe. I think
and Kenya and
US
everywhere.
and
Yeah,
Kenya. Yep. And they're different flavors. I mean, many people who remember the 1980s in the US will have an assumption about the sexual orientation of people who are HIV positive.
right.
Um, but then in East Africa, a lot of people have an assumption about the sexual promiscuity of someone who's HIV positive, or more commonly that something happened in their life or in the life of their family, and they've been cursed with this disease. That's a pretty
Hmm.
common tribal narrative around HIV, is that this is a curse from God, and so we want to separate ourselves, spiritually, emotionally, physically from the person or people who have tested positive. I think there's it's easy to say oh, that's a really backwards cultural narrative. But the same really spirit in the US narrative around it is the moral culpability of someone who's HIV positive. Whether you call it a curse from God or say it's their own fault, it's really the same social stigma and the
Yeah,
same isolation that people are putting on someone for having this horrible virus. And
yeah,
so I think depending on someone's life experience, depending on their age and their cultural background, there's going to be different flavors of stigma, but it's still a really highly stigmatized disease globally. But
yeah.
we've seen it really devastating for people living in East Africa.
Do you think it's more of those social, thinking about the kind of the moral culpability of if you have this disease, it might be your fault? That is the main source of the stigma, or is it this sense of being unclean? And I think there are some misconceptions, like you can't get AIDS by eating food after someone with AIDS ate food. You can't get AIDS by giving someone with AIDS a hug. Like there's some sense of I think there can be these misconceptions just about how the disease is transmitted, which and so yeah, what's the source of that stigma?
It's a combination for sure. There's
Yeah.
there's the morality of it. There's the fear. So much of stigma in general. Even when we think about in the U.S. mental health. I mean, we have a mental health crisis globally right now, and we deal with mental health specifically as it relates to HIV in our work. But there's still stigma around mental health diagnoses in the US. And so much stigma
Yeah.
in general, I think, is like pretty rooted in fear. And
Hmm.
whether the fear is, oh, I'm going to be embarrassed, or I'm going to catch this disease that I don't know much about, or I might get cursed if I associate with this person. Like the cultural flavor of that stigma, I do believe is all primarily rooted in fear. And so our clients who have experienced really extreme stigma, it's a combination of factors, but it's almost every story of every client when they come into our care. It's my family left me, my husband assumed that I was promiscuous, so he left. I was fired from my job because, they were afraid that I was going to pass the virus on to people. My church kicked me out because they thought that I had sinned. It's
Wow.
all of these different social spheres of influence choosing kind of their angle of the stigma and stigmatizing this person. And so people are just incredibly spiritually isolated, incredibly socially isolated. And people living with HIV, this is, correlation, not causation, but they're 3 times more likely to experience significant mental health disruptions, depression, anxiety, suicidal ideation. And it's certainly linked to that lack of community and a deep feeling of shame and culpability. And so it's a really, really hard social layer. We sometimes talk about the virus itself is really like the tip of the iceberg.
Right.
Like we can cure that. Well, we can deal with that really easily, frankly. It's everything else that comes with the isolation and the stigma and the mental health disruptions and the economic disparity that tends to be at play as well that make this a really hard thing to tackle.
Yeah. This podcast is about learning to love like Jesus.
Mm.
How do you see Jesus responding to stigmatized medical conditions? And can you unpack, like, as Christians, how should we think about stigma that comes with a disease? And I would just say,
Yeah.
regardless of whose
Yeah.
fault the disease is,
Yeah.
you know?
Exactly. Yeah. That's one of my favorite things to challenge people with, where it's like,
Like,
okay,
does
so
that even
like,
matter? Like, does
does it
that
matter?
argument?
Yeah.
Yeah, yeah.
Like it's such a challenging for Christians in particular. It's a really challenging and interesting thought to go down the road of like, what is sin other than stigma, right? Like we are being separated from community. We're being like relationships are broken, all of these things. Everyone has experienced stigma in some sense in their lives, whether it's related to mental health or relationship status or gender or, you know, name it. There's something that you've experienced in your life, no matter where you live or who you are, where you've been like afraid that people in your social networks are going to find out about it and think differently about you.
Hmm.
And so I think it's, the way that Jesus deals with stigma in general is to draw close. It's to come near. It's to be in the flesh. So many people, I think, rightly will associate modern HIV stigma with the stigma of leprosy in biblical times. And although the diseases are quite different, the kind of cleanliness rules around it and the social isolation and the stigma around it, they're pretty analogous. And what we so obviously see Jesus doing is like breaking all the rules of the Old Testament,
Yeah.
coming close, coming near. It was very, very possible, and would have been more socially acceptable for Jesus to have cured leprosy from a distance. He could have done it miles and miles away. He could have done it from another city. He could have done it in any way he chose. But time and time again, whether it's leprosy or the woman bleeding or women in general, like any stigmatized medical condition or person or ethnicity, we see Jesus over and over again choose to come close and to be in physical proximity and physical contact and emotional relationship with that person to initiate the healing. Um, and I think it's such an easy textbook to follow in the type of care that we give. And it's exactly what we've opted to do at Untold, is to say, like, primarily the way that we're going to walk toward healing together is in like really, really close proximity and relationship, and addressing not just the physical issues, but the whole person.
Right.
And so, yeah, I think it's Jesus is really into physical touch. One of his love languages, for sure.
Oh, that's an interesting claim, Molly. Unpack that.
Well, I think every time you see these healing stories, he's touching, he's reaching out, he's washing feet, he's sharing water, like these things that when you think about not only just the culture of the time and all of the purity rituals that were in place for Jews for appropriate reasons, is a whole different soapbox. But I believe that God revealed a lot of public health principles to us in the Old Testament through like purity rituals, where it's like, I don't want to explain trichinosis to you, so don't eat pigs. like giving us little hints about public health and how he designed the world before we knew about germ theory. But Jesus like kind of breaks down those rules for the sake of the Imago Dei, right? He's sharing water with someone who would be considered unclean. He's dining with tax collectors. He's letting sex workers be in really close proximity with him and touch his feet and touch his robe. He's touching people with leprosy. I think the love language of healing in Jesus is so often wrapped up in physical touch, and he never had to do that to anyone, but he always chose to. And I think that's such a beautiful thing that helps us like draw close to people physically.
Yeah. I love it. So thinking about Untold's work, working with a stigmatized population of people who are HIV positive, I just feel like what you're doing is, in your staff are like trying to be like Jesus and how Jesus would engage with this population. And I think one thing we'd get throughout the Gospels that would be undeniable is that Jesus would engage with this population, that if there was a stigmatized population, Jesus is walking towards them. And then how we do that in engaging the whole person of physical healing and spiritual healing and emotional healing and social healing. So tell us, how does Untold serve people who are HIV positive, and what do your programs look like today?
This is my favorite question, and I will give you like the very high level overview. When we do our internal orientations for new team members, the program orientation session is 5 hours long, so I'm not going to do that version.
Whoa.
Yeah, we give you lunch, but it's a long one. But
that would be like who's the guy who does the super long podcast? I can't remember his name right now. Oh my gosh!
Yeah,
Joe Rogan. That would be if this was like the Christian Joe Rogan. Yeah.
So what I like to say when we talk about it internally and externally is that HIV is an incredibly complicated virus. It's an incredibly complicated social environment that we're working in, and complex problems inevitably require complex solutions. So our program at its core is really simple and elegant, but the details of it take about 5 hours to walk through. But essentially, the high level version is that we believe that healing can start and should start in the local church. So we work out of existing hyper local, like little local, you've been to many of them, churches in informal urban settlements. That's primarily where we do our work throughout East and South Africa. So we start by finding a community that has a high burden of HIV and other social complications. So there's certain communities where we work where, all the communities where we work are extremely materially poor, but each also typically has its own social barriers at play in addition to their HIV burden and economic poverty. So, some of our communities are known for organized crime or sex work or, teen pregnancy or various social issues that are complicating life for people living with HIV in particular. So we're pretty data driven when it comes to which communities we want to work in. And then when we target a community, the first thing we'll do is find a church partner. So we work across, at this point, I think it's 17 different denominations, all Christian.
Wow.
But yeah, we are ecumenical. Like that is a core theological value of ours, is that we are an ecumenical ministry, which means that theologically we get to, I heard someone articulate this well, we get to create an airy room. Like on essentials, we agree. And on non-essentials, you're going to find all manner of theological inclinations among our staff and among our church partners. But core to our program model is that we work through local Christian churches. And what we do is we'll recruit a cohort of 80 men and women living with HIV from that particular informal settlement. And the way we do that's pretty unique. A traditional kind of clinic model would wait for a client to come and then kind of integrate them into the program. Our recruitment model is all incarnational. We go out and we find people who are bedridden, who have been lost to follow-up. Many of our partner clinics will give us a list of clients who they just can't find anymore, who have stopped coming, and we'll go out and we'll find them. We'll find them in their homes, we'll find them in their communities, and then we bring them into the program from there. So it's like a very active recruitment style, which is why one of our secret sauce ingredients is that all of our field staff, 100% of our field staff, are what we call hyper-indigenous. So not only are they Kenyans and Tanzanians and Ugandans, but they're people who live in the community that they're serving. And most of the time they actually grew up there. So they know these people. They know the culture of the community in particular. No one is commuting in. And so they'll go, they recruit their class of 80. And that group of 80 men and women go through a 9-month process together. And the core of the program is integrated care. So it's counseling-based interventions for physical, emotional, spiritual, and economic health. So we're really doing it all, which is why it takes 9 months.
How often do they meet?
They meet multiple times a week. So it's a really, really high-touch program, and it requires a massive commitment from our clients. Like really, our clients are absolutely the heroes of their own story because they're committing such significant amounts of time and energy to their own healing, and our staff get to kind of Sherpa them along that journey. So there's about 7 touch points a month. So there's one-on-one counseling for physical health and for emotional, spiritual health, all based in cognitive behavioral therapy. Our curriculum is 600 pages of really beautiful, best practices informed, scientifically backed content.
Your curriculum is 600 pages, Molly.
It is. It's a big one. But part of that is that we want our counselors, who are not licensed clinical social workers, they're not clinical counselors. We use a task-shifted model where our field staff, the health counselor and the spiritual counselor, they are entering into some of the most complicated and traumatic life stories that any of us could imagine. And so the 600-page curriculum is really, my programs director calls it a love letter to our counselors, because there really shouldn't be any scenario that they come up against that we don't have a tool for or a referral for or a guideline for. For example, we do home visits. So there's one-on-one counseling, there's group therapy, there's home visits, there's economic empowerment training sessions, savings groups that we partner with Hope International to do. But in these home visits, many of our staff have entered into active domestic violence situations. And we want to ensure their physical and psychological safety as much as we want to ensure our clients. And so we have All of our staff are certified in de-escalation techniques, and they're always getting trained. So much of our
Yeah.
job is to train and equip our field staff with the best of the best content and tools. And then they're supervised by clinical professionals who are also Indigenous. So the whole thing, all 9 months, the clients are coming to the church multiple times a week, and then our staff are going to their homes once a month to ensure that they have everything they need to really significantly heal. The goal for every single client is that they achieve viral suppression, which means that they will not transmit HIV to a loved one or a baby and are functionally kind of transitioned into that chronic illness category. And that they have the tools emotionally and physically to maintain that viral suppression for the rest of their lives.
So what, yeah. So what you mentioned kind of people that you look for to recruit for the program maybe are not going to the clinic, and they used to be going to the clinic and now they're not going to the clinic. So why would that happen? So that means that they were taking medication and are off their medication.
That's right. Mm-hmm.
So what are reasons why people would not adhere to a antiretroviral regimen?
This is really the heart of our program. It's it's who we exist for. We exist for the people who are so vulnerable, and kind of we call it the last 5%. Like those people who have fallen between the cracks and who have defaulted from they're lost to follow up. They're not on their regimen anymore. And the primary reason for non-adherence in HIV or in any type of long-term chronic illness management is a sense of self-worth. We have the whole approach. The whole approach is based on we can't expect our clients to heal physically until they heal spiritually and emotionally. A story that's a really helpful example of this that my program director, Chelsea, tells all the time. She's a licensed clinical social worker who was in local Atlanta hospital settings before she joined our team. And she was a social worker at a children's hospital. And they had this client who had diabetes and had all of the access to what he needed to manage his diabetes, but he was constantly coming into the emergency room in DKA. So he was just not adhering. And it was just like clockwork. He was coming to the emergency room, coming to the emergency room. And so they called her in as a social worker. And when she got to the heart of the matter, this young man said that he believed that his mom's life would be easier. It makes me so emotional if he wasn't around. And so his sense of self-worth and the shame and burden that he felt because of his sickness and because of how much he cared for his mom prevented him from being emotionally able to adhere to his medication.
Yeah.
The same exact thing is happening for our clients. If they've been told by their churches, by their spouses, by their families, by everyone around them that they don't deserve to live, then why would they invest the money and the time in keeping up with their medication, feeding themselves, getting out of the house, earning a living? We are such integrated beings. My physical health is so dependent on my mental health. I'm not going to even work out if I don't feel like I'm worth investing time in. And it's so much greater for our clients, which is why we say stigma is more deadly than sickness, because they have the access. Really, there's no reason why anyone should default on their ARV medication. The core is that if you do not believe fundamentally that your life is worth living, you will not adhere. And so that's why we take a counseling-based approach and have incredible stats of how when clients are transformed spiritually and emotionally, their physical health follows suit 10 times out of 10.
Yeah. I think this is a common misunderstanding of poverty in general here. There's a idea that if you're in poverty, if you're really disciplined, you can climb out of poverty. But I think people misunderstand that actually self-esteem and a sense of self-efficacy and are far more likely to make you disciplined than shame and desperation.
Oh my goodness.
And there's a study in Poor Economics, which is a book by Abhijit Banerjee and Esther Duflo, that talks about this. And basically they measured who is more disciplined, people who have hope or people who have
Yeah.
fear and desperation. And the people who have hope that they can work towards a better life are actually the ones who are going to be more consistent. So that's a lesson. That's like a little self-helpy kind of lesson for, I think, all of us, frankly. But we should think about that when designing development programs of, I think that is one problem with the pull yourself up by your bootstraps narrative, is that, I think any successful person who's really honest with themselves and their story will name a lot of people who helped them up along the way. But that's really powerful, Molly. And yeah, I feel like we're getting to kind of the deeper things, that, Untold is really working on above just kind of, maybe providing medication, or, that's not really even the main thing. The main thing is this, affirmation of the dignity of people who are socially marginalized, and their dignity and self-worth. How many people are impacted by Untold's programs per year at this point?
We just hit a huge milestone last year. We graduated our 50,000th graduate.
Wow.
Which is so incredible to think about, because when we talk about our clients and a life beyond AIDS, it starts with the client. It doesn't ever end with the client. Our clients are some of the most generous and generative people I have ever interacted with in my entire life. Just because they're materially poor doesn't mean they're not incredibly generous. And so when I think about those 50,000 clients, I immediately think of the hundreds of thousands of dependent children that not only, like, baseline here is like they're not going to be orphaned. That's awesome.
Right.
And that's like the floor. Like, that should be like the lowest bar possible, is like, these kids will not grow up orphaned because of HIV. What's even more exciting to me than that is the layer of, like, these kids are growing up in homes with emotionally intelligent and healed parents who are guiding them through, like, spiritual transformation, and have access, not just access to the gospel, but more than that, access to a local church community that's going to continue to care for them and pour into them and pour into their families. And so these kids of our clients have, like, such an incredible head start, because not only are their parents going to live, but their parents are going to live full, in, like, rich, beautiful, flourishing, like genuinely flourishing lives. And there's nothing healthier for a child than a flourishing parent. And so that's the gift that we get to give to these kids. Not just like, oh, your parent's not going to die anymore, but it's like, no, they're actually, like, flourishing, which is very, very exciting for me.
Yeah, that's awesome. I want to talk about PEPFAR. And I want to ask you about the current status of PEPFAR. First, I think when I was giving my little of history of AIDS, I think I got maybe some of the dates wrong. And so I think you will do a better job at giving us the history of PEPFAR than I will. Tell us, what is PEPFAR for people who do not know? How did it start? What was the role of Christians in the start of PEPFAR? And can you just give us a whole PEPFAR story from beginning to last year to now?
Whole story. Yeah, definitely. I'll do the flyover, and then you tell me what's most interesting to dig into. But PEPFAR stands for the President's Emergency Plan for AIDS Relief, PEPFAR. And it was started by George W. Bush in 2003. So to your point earlier, kind of the height of the global epidemic, there was this call for action from the global community, particularly from the West, to say, like, well, somebody needs to step in and figure out how we can provide access for people living with HIV around the world, because it was, as we talked about, massive orphan crisis, entire communities really devastated. So George W. Bush started this initiative in 2003, and it was really such an incredible legacy of bipartisan partnership. And it's a little bit complicated. I won't get into too many of the details, but it's essentially a package of funding that George W. Bush started for a number of things, specifically access to HIV medication. So PEPFAR is what has, since 2003, made antiretroviral medication available for free throughout sub-Saharan Africa. So it's typically bilateral funding, so government to government, for prevention services, for access purchasing and access to medication. There's some pediatric prevention programs in there, but essentially it's like a massive budget line item, for lack of a better word, from the US. And the US was leading the way. Now other Western governments and private entities have also partnered alongside PEPFAR to create the Global Fund against AIDS and malaria. And so it's saved, 20 million people are on treatment.
I just Googled it, 26 million people.
There you go. Yeah. And like millions and millions, I think like the number is over 5 million babies have been born HIV negative directly because of the medication access that PEPFAR funding has made available in sub-Saharan Africa in particular. And so the complicated thing about PEPFAR is that it's this kind of budget item, and it's historically was implemented through a number of other partners like USAID, CDC, Global Fund. It's kind of this private-public partnership, which for the policy nerds listening, HIV in the U.S. was really, in the 1980s, the HIV crisis was kind of the first massive U.S. public health crisis that created this like normalcy around public-private partnerships within funding and program implementation. So it's really changed the way that public health and health services works in the U.S., but then also globally, these like really massive public-private partnerships, which is pretty cool. So PEPFAR is the funding mechanism. We all are probably aware that in 2025, USAID was dismantled as a part of a massive kind of overhaul of public policy and global health policy. And as a result, PEPFAR itself, this is where it gets so complicated because there's so many parties involved. But the way that PEPFAR was set up was every certain number of years, there was like a reauthorization vote. And that reauthorization would secure the funding along with a bunch of different, I have like a whole chart of it that I trained the team on years ago, a bunch of different little details about the funding and, percentages and bilateral funding and public-private partnerships and which programs it would fund to essentially keep the funding secure for cycles of years at a time. It was not reauthorized and has gone to kind of an annual budget approval process. And so the danger with PEPFAR right now, I think a lot of people kind of conflated the dismantling of USAID with the cancellation of PEPFAR.
Right.
They're really linked, but they're not the same thing. Experientially, though, it doesn't really matter because, like, on the ground, much of the PEPFAR funding, the programs that were implementing that
USAID, boots on the ground. Well, USAID, I think 80% of their funding was through contractors as well. So does that mean it would be like contracted and contracted, or? Okay.
Yeah, and there's like subcontractors, and you depending on the mechanism of funding. It's very complicated. But essentially, USAID, in a lot of instances, was an implementer of PEPFAR-funded programs and medication. So, for example, there would be a clinic in a community that is run and staffed by USAID employees who are local, but employed by USAID, and they are giving out the medication. They're doing the testing, and they're, handing out the ARVs. When USAID was dismantled, that clinic, those staff were put on furlough and then let go, and that clinic was shut. The medication was still there, but there was no longer access to the medication. So there are horrible instances that you can read about in 2025 where shipping containers full of ARVs or the specific type of ARVs, nevirapine, that is meant for pregnant mothers to prevent HIV transmission from mother to child, were just locked in warehouses. So there is availability, but not access because of the USAID issues. So today, PEPFAR is still, it was reauthorized, or not reauthorized, but the budget for 2026 is actually more significant than a lot of people estimated. It's still a relatively bipartisan program. Like, I think when push comes to shove, when you look at the details of it, it's hard to find anything horrifically negative about funding medication access in particular, which is how we interact with PEPFAR. So in February of this year, President Trump did sign a bipartisan bill to spend $5.8 billion, which was much more than people estimated. Around $3 billion was the estimation. And so that's significant. It's great.
That's great news.
Yeah, it's great news. I think there's still a lot of fear and uncertainty around, like, will that continue to happen? A new thing that was also added to that bill, which is really exciting to continue the funding, was this initiative for the State Department to essentially create a plan for a multi-year phase out for certain countries so that there's some structured handoff. That's happening most quickly in South Africa. And frankly, South Africa has been initiating, even before it became a U.S. priority, kind of independence from global aid when it comes to the HIV response. The timeline of it is definitely feeling hard for some South African programs, but the structures are in place in certain countries to kind of wean off of this type of aid. In certain countries, though, my personal soapbox sometimes is like, there's just not a market solution for everything. Like, there will be inevitably countries and communities that cannot meaningfully address their health issues without external intervention for a longer time than might seem reasonable to a typical American. And so where we are today with PEPFAR is, we're not in immediate risk of it being cut off, like the faucet's not being turned off, but there is definitely uncertainty around the timeline of the plan, uncertainty around the continued budgetary line item, because now every year, because of the lack of reauthorization, it's kind of up for grabs again. So if you are passionate about it, you should, get involved, learn more, go to DC.
Email your representative. Well, yeah, I mean, you can get meetings with your representative without traveling to DC. Just shoot them an email and ask for a Zoom call. I just actually did that the other day for a different nonprofit.
That's awesome.
And so, well, that's excellent news, Molly. I did not know that the reauthorization went through in February and that the budget was larger than people expected. And so that's really encouraging news
it's encouraging that I think even in an America First reality right now, people can see, in a bipartisan sense, the benefit of, I mean, from a Christian perspective, really, there's no question. But even from a geopolitical perspective, I think, being present in developing countries and helping toward that development, particularly around health programs, is a good thing. But yes, we even experienced a lot of devastation around the USAID shutdowns. We stepped in. We were really, really, really proud and grateful to have been able to step in 2025 and spend a couple $100,000 on procuring medication when our clients didn't have access anymore. And so none of our clients
you did see in clinics in Kenya, ARVs dry up.
Yep. And particularly our pregnant clients did not have access to the medication they needed. So some generous private donors of ours stepped up and helped us fund. We figured out how to get wholesale medication and get it to our clients. And, it's just not a long-term sustainable solution for programs like ours. Like, we are built a foundation of medication being globally accessible and free. And when that shifted under us, there was a lot of fear in our communities, for sure.
Yeah. What's next for Untold? Where do you see the Lord leading the organization over the next few years?
We are in a season. This is actually very exciting and kind of new news for non-really tight insiders. We have actually
I consider myself a moderately tight insider. I should disclose that my best friend from college is the director of operations of Untold.
You are tight. But I'm really excited to say that in 13 of our communities where we've been working for more than a decade, we've actually served everyone who meets our vulnerability index. And so we've reached a sustainability level in 13 areas. And so we've graduated those communities, and the churches themselves are now caring for the people forever. And so we get to take those resources and go to places who still need us. But over 10 years, we were able to serve thousands of men and women who are now virally suppressed. And one of my favorite experiences happened in January of last year in one of those communities where we closed. I was at a graduation, and we'll often have our community partners stand up at the graduation and introduce themselves. And it's usually like, doctors from local hospitals and local nonprofit leaders who have, partnered with us in X, Y, and Z. And two of the leaders who introduced themselves were explaining their public health NGO and how they helped with the program this year and what resources they provided our clients. And two of them said, also, by the way, I'm a graduate of this program. And so we're not only seeing our clients graduate and, like I said, live, but we're seeing them go and become leaders in their community and take the work from us and run with it locally. And so kind of our next couple of chapters, I feel like, are graduating entire communities, kind of watching that sustainability play happen, and then going to find that last 5% in new areas, particularly in South Africa, which is really exciting.
One of my favorite things I sometimes hear nonprofits say is our goal is to work ourselves out of a job, to work in a community and then no longer be needed. But I love that Untold has a vision for that in the places where you serve. There's actually a point where locals can own it and care for this group of people, and we can go off, like you said, to another community. Molly, this has been so fun. I'm so grateful to just spend this time together and learn from you on this crucial issue. And I think one of my big takeaways from our conversation is this idea, of stigma and of Jesus walking towards the people who are stigmatized. And I think for all of us, that is an invitation to be like Jesus and to, maybe none of us can do everything, but to find a particular thing that God is calling us towards, especially around a particular group of people who are on the outskirts, and bring them in and affirm their dignity and worth. As we're closing up, what is one thing that you're learning in this season of life about what it means to love generously like Jesus?
In this particular season of life, I'm learning from my kids the most about what it means to live generously. And that expresses itself in a million different little ways. But in particular, my son is just so thoughtful. And, anytime we see someone experiencing homelessness or, he has questions about certain things, it's such a fun conversation to have with him. And he's so genuine and he's so curious about who they are. And I think that is just the model. For me, the childlike faith is just it's not a silent, okay, I'll do what I'm told. I don't know if your kids are like that, but my kids, their faith in me is that I will enter into curiosity with them. And most recently it's if someone is asking for money, he's more curious about what's their name? What's their deal? Where do they live? How can we be in a relationship with them? How can we help them? Yeah. And that level of generosity of seeing the person before seeing the need, it's such a beautiful continuous reminder that God's inviting us into curiosity about how we can be generous, not just financially, but in the way we want to know people. And I think that's really in my heart these days.
The invitation to grow this week is to pray and ask God if there's a group of marginalized people that He is calling you to take a small step towards. And then take that step, whatever it might be that He brings to your heart. Thank you so much to Molly Heacock for joining me on the show. If you have feedback on this episode, you can reach me at brian@simplecharity.org. Next time on the show, a conversation with the founder of a Christian camp that enables thousands of kids to have moments with God every year. I hope you join me as we continue to learn to love generously like Jesus. Have a great week. See you next time.